do that, just some quick house rules, as you know, that we have facilities for you to ask live questions. So please indicate if you'd like to do so. That is in the Q&A section of the Zoom app. Please use that to ask a question, preferably indicate to whom you're asking the question and identify your news organization, please, or the entity which you're representing today. And we're also live, so we're simulcasting in both English and French. Use the globe icon at the bottom to choose your preference. Francois?
Bonjour et merci à tous de vous être connectés à ce briefing. Donc, il est possible d'accéder à un flux audio uniquement en anglais, uniquement en français, en utilisant l'outil d'interprétation de Zoom qui ressemble à un globe dans votre barre d'outils. Pour les questions, merci d'utiliser le Q&A, d'indiquer votre nom, votre média et si vous voulez que nous prenions votre question en direct. Merci.
Thank you, Francois. So let me please introduce you, colleagues, to our esteemed panel. Joining us from Brazzaville, the Republic of Congo, is Dr. Moeti, who is the WHO Regional Director for Africa. As you know, she's joined today by Dr. Nsenga Ngoy. From Nairobi, Kenya, we're joined by Professor Ifedayo Adetifa, who's a clinical epidemiologist at Kemri Wellcome Trust Research Program, and he's also an associate professor at the London School of Hygiene and Tropical Medicine. Welcome to you. Regina Kamaga is the Executive Director, Community Health and Information Network, or CHAIN, and is chairperson of the Uganda Alliance of Patients Organization. She joins us from Kampala. Very good to have you. So let's just open up the floor. Dr. Moeti, we start with you. What can you tell us about how COVID-19 is impacting essential health services on the continent as a whole?
Yes, thank you very much, Tsepiso. And good morning, good afternoon, bonjour. And I'd like to thank all our colleagues from the press for having joined us for this press conference today. Indeed, to discuss how COVID-19 has impacted on the provision and on access to essential health services in Africa. I'm really pleased to be joined for this conversation today by Professor Ifedayo Adetifa of the Kemri Wellcome Trust Research Program and the London School of Hygiene and Tropical Medicine, and by Ms. Regina Kamaga, who is the Executive Director, as Tsepiso said, of a Community Health and Information Network, and also chairs an alliance of patients organizations in Uganda. I'm also joined by my colleague, Dr. Ngoy Nsenga, who will answer some of the questions.
Are you back with us? Okay, we're going to have to then move on. Perhaps let me come to you, Professor, to just talk to us about your situation. What experiences have you had in terms of missed immunization campaigns? I know that South Africa is having that conversation right now, and in fact has kicked off.
I think we have Dr. Moeti back, so we could actually go back to Dr. Moeti.
All right, thank you, Saya. So, Dr. Moeti, I believe we have reconnected with you, so let's give you back the floor.
Okay, I'm sorry about that. So maybe if I can just start off where I had left off. Collins. I was just saying that many countries have been spared the worst of the pandemic, and I just gave the number of cases we've seen, and we've had many conversations about why Africa hasn't been as devastated as had been predicted. But we're very concerned about the fact that there is a knock-on effect for health in Africa. And even as countries respond to the pandemic, it's really important that other life-saving services continue to be available to communities. So a preliminary analysis by WHO indicates COVID-19 is hitting other health services really hard. We've looked at indicators in 14 African countries like outpatient consultation, skilled birth attendance, malaria treatment, And we see a sharp decline in the uptake of these services in 2020 compared with 2018 and 2019. The biggest gaps were in May, June, and July, when many countries enforced restrictions on movement, as well as other social and public health measures, the so-called lockdowns. In these 3 months, we witnessed a drop of more than 50% on average in the services we monitored. An extra 1.32 million children aged under 1 year missed their first dose of the measles vaccine from January to August 2020 compared to the same period in 2019. And in Nigeria, for example, more than 362,000 pregnant women missed antenatal care between March and August. And in August alone, there were 310 maternal deaths in health facilities, almost double the number recorded in August 2019. So while COVID-19 is not overwhelming African health facilities in the way that many, including ourselves, first predicted from some models, it is really stretching already resource-limited health systems. Staff resources have been diverted to the pandemic response, and barriers to service access have increased with the pausing of immunization campaigns, with financial hardship on the part of families. We know that in most African countries, a lot of the financing for health comes directly out of the pockets of families and individuals. And also, people are afraid of coming to health facilities, and there is other fears that are triggered by misinformation around COVID-19. Together, authorities, partners, and communities really need to do more to protect the hard-fought gains made over many years in improving access to care and health outcomes in African countries. The good news is that some delays reported earlier in the year are being overcome. In many countries, immunization campaigns have restarted, protecting tens of millions of children from diseases like measles and polio. At WHO, we're advising countries on ways to provide essential services safely with protections for healthcare workers and community members. And we are assisting countries to address stockouts of essential medical products. We've also set up monitoring systems with 22 African countries to track data on service delivery in around 4,800 health facilities in real time, so that any drops in access can be investigated. The continent has been experiencing a plateau in COVID-19 cases since mid-September, but in the past few weeks, we are seeing a concerning uptick in some countries. So it's too early to say if this is the start of a so-called second wave, as we are seeing in Europe and elsewhere. But with COVID-19 already crushing economies and disrupting key health services, we mustn't leave the door open for the virus to resurge. So in line with further reopening of economies, individual protective behaviors need to be reinforced. This is imperative to continue easing the restrictions safely. I have to say, communities have shown great fortitude in this response, and a huge effort is still needed by individuals to keep wearing the masks, keep a distance when it's possible, and practice frequent hand hygiene, and by authorities to scale up smartly targeted public health interventions to localize the response. Together, we can save lives by ensuring access to essential health services and getting livelihoods back on track. So I look forward very much to our conversation today, and thank you once again for having joined us.
Thank you very much, Dr. Moeti, and some very concerning figures that you have mentioned there, as you say, double the number of maternal deaths that we would have seen as a result of the impact of COVID-19 on essential services, life-saving services. Let's hear now from Professor Ifedayo Adetifa what the consequences of missed immunization campaigns have been where you are and what can be done.
Thank you very much, Piso. It's indeed a privilege to be at this presser with Dr. Moeti and Ms. Kamaga. Dr. Moeti has set the tone for what I was going to talk about, which, as you've asked, is the impact of the pandemic on measles outreach services. So In April and May, the WHO survey of countries indeed confirmed the extent of disruptions to not just routine immunization services, but indeed to outreach services, which includes what we call campaigns or supplementary immunization activities. The good thing is, while we've had some recovery of the routine services, the recovery of outreaches and campaigns have been a little slower, but thankfully there have been some gains in that respect. And we are particularly worried about measles because this is a highly infectious condition, very easily transmissible. For every single case of measles, you can get about 18 to 20 more cases in a susceptible population. And of course, this is all dependent on the circumstances of mixing of settings. So in our camps for IDPs and other congregate settings in slums, that risk is even higher. Now, the thing with measles in particular is because it's such an infectious condition, under normal circumstances, it requires very high vaccination coverage levels to produce the level of immunity required to interrupt transmission in communities, and this is typically 95%. Now, the thing we have is, even when routine services are running in a lot of countries, this above 95% level of measles coverage, measles vaccination coverage that we require is not achieved in many countries. And what that means is that every year, or for every batch cohort, you have a proportion of susceptibles that enter the rest of the population without being vaccinated. And this number accumulates and increases over time, because as you know, there are babies born every day, there are batch cohorts every year. Now, what happens is that to prevent an outbreak in this pool of susceptibles, we conduct measles vaccine campaigns, okay? The campaigns may target all under 5s, or sometimes may even target up to all under 14s. And it is those campaigns that have been severely hit by the COVID pandemic. So what is happening is a combination of reduced routine services and interruptions or disruptions to campaigns is resulting, as we speak, in an increase or an accumulation of babies, of children that are susceptible to measles in the population. And once you've got introduction of one case, then there's a big risk of outbreaks occurring. And specifically where I am, we have looked at population immunity to measles by testing for antibodies and done some modeling work to predict the risk of outbreaks. What we found is when COVID restrictions were at their maximum, those restrictions actually helped reduce measles transmission, because it's the same circumstances. You reduce mixing, you reduce people moving around, you take children out of school, and so on and so forth. But what is happening is that with the easing of restrictions in different levels in various countries, including where I'm based, the risk for an outbreak is increasing. And we project that by this, if all restrictions are eased by December 2020 in Kenya, and vaccination coverage for measles is reduced by 50%, we may have a risk of an outbreak, of a large measles outbreak. And this scenario is all dependent on the level of coverage achieved. So we have scenarios for 15%, for 100%. Now we have to remember, not just in Kenya, but in many countries, there are already pools of susceptibles in areas where the immunization program already had problems reaching children with vaccines, and all of these children are therefore at risk of outbreaks even as we speak. I'll stop there now. Thank you.
Thank you very much, Professor Adetifa. So that has been the Kenyan experience. Let's now find out what we can learn from the Ugandan experience. Regina, Kamaga, you can tell us about the work that's being done, especially to patients accessing essential health services.
Thank you very much. I'm very delighted to be part of this. press briefing. Indeed, the impact, just as my fellow panelist has highlighted, has been huge and still is. But of course, all is not lost, as many development partners, civil society organizations, and especially patient organizations in Uganda have made efforts to ensure that these services continue. And many of them have supported people living with different conditions. The Uganda Alliance of Patient Organizations is an organization that brings together patients across different diseases: HIV, epilepsy, cancer, sickle cell, hepatitis B. And during the lockdown, many of their treatments were interrupted, but efforts were made by the patient organizations to ensure that they help them receive care, they help them with psychosocial support and other mental services. And as such, together we're still putting up efforts to ensure that this is done. On the other hand, the biggest gap in this response, initially, the top-down approach worked very well, where the leadership was very critical in terms of combating the spread of the virus with all those measures that were taken. But again, the gap was at the community engagement level, where the community-owned resources were not really involved. And these community resources are very critical. And I'm glad to say that in Uganda, the Ministry of Health has developed a national community engagement strategy, which is aimed at strengthening existing community health systems for integrated people in Uganda, because right now we are in phase 4 of the pandemic. And again, there's a lot of complacency at the community level and the need for involving community, empowering them through health literacy, patients through being able to self-manage their conditions, telemedicine, and all that is very, very critical. And also in terms of government committing more funding to the health sector. The budgets are still low, especially in many of the African countries where we have not yet met the 15% of the Abuja commitment. National health insurance is still a challenge, impacting universal access. But we believe that with all the efforts of all the key stakeholders, and particularly the patients and the community, we believe that we will go a long way, because, like I said, the community-owned resources, the village health teams, the community health workers are better placed. They're placed in the community. They're trusted in the community. They're the first point of contact. So being involved in the response in terms of community surveillance, contact tracing, demystifying the myths and beliefs, and raising the issue about the disease, and again, the issue of complacency, all that goes a long way into helping us respond as we wait for the vaccine, and of course, considering the patient safety of our patients.
Thank you very much, Mrs. Kamaga. So there we have it, the expert account, including the patient account. So it's time for the colleagues now to ask their questions. Remember, I did mention that if you wanted to ask your question live, you are able to do so. Please use the Q&A function of the Zoom app to raise your question. We do have a live question already, and I want to make sure that we've got Naftali Mawara from Shinwa on the line with us. You have a question to ask. Naftali, are you with us?
Yes, I'm with you, Dr. Pisa. Thank you.
Okay, great. Go ahead.
Can I ask my question to Dr. Moeti? Dr. Moeti, I just want to know what has been done so far to ensure that access to essential health services continues in this continent, despite the interruptions occasioned by COVID-19.
Yes, thank you for that question. We've worked very hard with our team, both here in the regional office and our country office teams, of course, who are working directly with governments to advise and support the restoration of essential health services. And I have to say that at the global level, some of the key partners who support programs to deal with specific diseases, for example, the Global Fund and Gavi, the Vaccine Alliance, have also played their part in terms of making sure that the financing of the areas that they're supporting is sustained. And they've encouraged governments very much. For example, at the very beginning, some countries felt with all the work that they are doing on COVID-19, they wanted to postpone the timing of some of their financing from the Global Fund. And the Global Fund was very keen for them not to do that and to ensure that they use the financing for that purpose in this adjusted way, and at the same time, of course, contributed to the pandemic response. As WHO, we developed guidelines at the global level on how to safely provide services in the most efficient way in the context of responding to a global pandemic as well. We have a task force here in the regional office. They adapted those guidelines to our region. They have been now sent down to our country offices, and they are working with ministries of health and other partners, including partners in the UN, on how to do this safely. And we know that most importantly is the need to make sure that people don't gather in the traditional way of coming to a health facility and run the risk of getting COVID-19. We're also encouraging what we call triaging. So making sure that we find a way as people get into the healthcare system to separate those who might have symptoms that are likely to relate to COVID-19 from all the rest, and also encouraging scheduling of services so that you spread out the degree to which people are gathering together. It's got, of course, it's got implications of the duty times and the rosters of nurses and medical doctors, and encouraging also outreach type service delivery so that people are rather reached at home rather than coming together at health facilities. This, I have to emphasize, has cost implications. It's got implications of mobilizing additional healthcare workers. So we're also speaking with partners and encouraging them to support our governments in order for them to be able to put this into effect. We have, the lockdowns also caused, we know, border closures, the stoppage of flights. So we're working with partners like UNICEF to help procure essential medicines. Some countries were just running out of essential medicines, and making sure that those become available through some of the humanitarian flights that we have been, that the World Food Programme has been operating on behalf of the work that the UN is doing to support countries.
Thank you so much, Dr. Moeti. Professor Adetifa, would you like to add to that?
No, I think Dr. Moeti has actually covered what needs to be said with respect to that question. So
okay.
That's fine.
All right, that's fine then. So let's go then to our next question. It's from Reuters. Omar Mohammed, I believe you would like to ask your question live as well. Are you ready?
Hi, good afternoon. I have a couple of questions directed towards Dr. Moeti and Professor Adetifa. The first question is something that you alluded to, is related to something that Dr. Moeti just alluded to in our opening remarks about seeing an uptick in cases across the country. Here in Kenya, we've noticed that too. What is your view on this specific situation where we're seeing a rapidly rising number of cases and straining health systems? And do you expect to see, a similar trend on the continent facing similar problems, especially as we're seeing a spread in rural communities on the continent in the coming months? Shall I ask my second question or first wait for that to be answered?
Okay, please go ahead so that we can just get it all answered all at once.
Okay, my second question is with regards to the coronavirus vaccine. So Cuba is working on its vaccine, which is in early and relatively early and mid-stage trials. I just wanted to get a comment from WHO about whether they've heard of the vaccine, and are there any conversations happening with Cuba about perhaps, you know, engaging in with them on the distribution of that vaccine, in taking having African countries taking part in trials. And in the past, Cuba obviously has developed vaccine, the meningitis vaccine as well. And how much has WHO worked with Cuba in the past on vaccine development and importing or recommending it to other countries? And what's the percentage or approximate share of it, of the vaccines that that has been recommended, includes Cuban vaccine? And then lastly, are Cuban vaccines historically cheaper than those produced by other multinational pharmaceutical companies as well? Thank you very much.
All right, thank you, Omar. Dr. Moeti?
Okay, thank you for those questions. Yes, as I said, and also my colleague said, Dr. Adetifa, Professor Adetifa said, we are seeing, and we have observed in some countries and are projecting, if action is not taken, to work differently and to try to address the reductions in coverage and access of services, that indeed in several areas, and I won't cite them, access to family planning, maternal health services, unfortunately resulting in some deaths, access to antiretrovirals, people with chronic diseases getting access to their treatments. I think Ms. Kamaga also outlined that we are seeing these reductions. And, you know, we're very concerned, for example, that even malaria cases and deaths might significantly increase if some of the interventions, including the preventive interventions, are not restored to the rate that they were before. So our drive, so in short, if there is no purposeful action taken to ensure that services are delivered despite the pandemic, we will see these impacts, and we will see an increase in the cases, illness, and death due to these diseases. And what we are doing now is to help countries to, at the same time as responding to the pandemic, really make sure that we adjust the way we encourage people to come forth for services. And luckily, the measures, most of the measures are being eased progressively in countries, and we ourselves go out proactively and we deliver services in ways that will ensure that these gaps do not widen, but that there is no risk of increased transmission of the virus. So it's something that is actively being worked on in countries now. Sometimes it's including running campaigns so that we catch up, especially in immunization. And I'm very glad that my colleague referred to measles, because it's a prime killer of children if there are too many that are susceptible. So there is active action going on. I think what we must emphasize is that this has resource implications. So the work of reestablishing or mitigating, in fact, against what you might call collateral damage in health and deaths due to our response to the pandemic really does need to be taken into consideration by the partners. And I was very encouraged by what Ms. Kamaga said about that in Uganda, partners are already coming on board to support people at the community level. And that's a very important level at which we need to intervene, as well as in the healthcare system itself. With regard to a Cuban vaccine, we are not aware of a Cuban vaccine having reached the late stage of trial as WHO. But having heard this question from you, we can go and find out perhaps from our colleagues working in WHO in the Americas, who are closely working with Cuba on a day-to-day basis, if this might be something of which they are aware. So we're not working with Cuba on a vaccine, as far as I know, and as far as my team are aware, but we can find out if there's information on this. We know that in the past, Cuba has produced vaccines for use for its own population to deal with some of the childhood diseases. So the capacity is there in the country, but what I'm not aware, and we are not aware of a COVID-19 vaccine yet.
Thank you, Dr. Moeti. Professor Adetifa, you spoke earlier on about the modeling, the studies that you've done to predict the infection. So if you could just talk a little bit more about that from the Kenyan perspective, because I think Omar also wanted you to perhaps just repeat some of the stats that you gave earlier on, especially around the spread of cases of COVID-19.
Well, thanks, Steffi. So I'm not sure that's so. The modeling results I referred to were specifically about the risk of measles outbreaks, not of COVID-19 outbreaks, which is the question Omar has asked. But I can understand Omar's concern, and especially with what's going on in the United States and in Europe. I think the question for the continent really is, do we actually have a second wave, or do we have a continuation of the pandemic as it starts, as we had since about February, March in most countries? Because there are various reasons at play here. We have the pandemic in most countries. It didn't have the same impact as it did elsewhere. But now we're in a situation where restrictions have been relaxed to varying degrees. The pandemic in a lot of countries started in the urban areas, especially where there are airports and port services, and peaked there. But the rest of the countries, other parts of the country, more rural or peri-urban, are perhaps catching up now. And I think the other thing to realize also, in many countries, including Kenya, where Omar is based, there also have been quite a number of variations in the testing practice. So, for example, if you're testing people if testing is suddenly prioritized for people who are sick, then your numbers go up. Versus if you're doing sort of widespread population level testing that might include a lot of asymptomatics and all of that, then you might have a different scenario. So the cause or the definition of a second wave at this moment is not, in my personal opinion, is not entirely clear, and we will need some time to accumulate enough data to tease out what exactly is going on. But the thing is to recognize that all of these things that happened is that we had an urban outbreak initially, and it takes time, especially in many countries, where restrictions were initially put in place for the pandemic to spread to other regions. And what we probably are seeing is a mixture of all of these various factors that I've mentioned contributing to new cases arising elsewhere. Regarding the vaccine, Dr. Moeti has answered from a WHO perspective, but I just think it's important to mention that I'm not sure myself what the last count of candidates COVID vaccines are. There are over 50 candidate vaccines, and if you add maybe very early stages, preclinical or plans for phase 1, they probably will be approaching 80 or thereabouts. But I think the important thing to mention is that I am aware, as a member of the regional immunization technical advisory group, and as part of global efforts, that there is a lot of background preparation to get ready for the availability of a licensed vaccine. So if any vaccine makes it through the late stage trials with demonstrable efficacy, there are processes in place, regulatory, community-based, and just in every area that is required. There are efforts in place to be ready for that. Now, this is a global pandemic. We will need, several million doses of vaccines to cover the entire world. In fact, we will need to find ways to prioritize who gets the vaccines first. For example, if there are limited doses, do you want to vaccinate healthcare workers. You want to vaccinate other non-healthcare frontline workers, truck drivers, people who work in the airline industry, in the ports. You want to vaccinate the elderly. So preparations for the availability of a vaccine, including helping countries prioritize who gets a vaccine depending on availability, are very much in the works. And I'm privileged to be part of some of those processes. And I am sure that Dr. Moeti will agree that WHO and all the global partners will look at any vaccine that works. And that's the issue. But all vaccines have to go through rigorous testing, demonstrable efficacy, and more importantly, demonstrable safety before they get considered for use in general populations.
Professor, thank you very much. Let's move on the conversation. And I do want to remind colleagues that we do have Mrs. Kamaga here who can talk about the patient experience, as she has already mentioned that there is a gap. There's community complacency, she said, and there is a need for community surveillance. So you are more than welcome to pose questions to her as well. But let me go to Dr. Ngoy on this issue of a second wave. I know David Marbury, you from Farm Radio International had said that Dr. Moeti was giving case data, but Dr. Moeti, you weren't really giving figures. I think you were saying that there is a spike that has raised concern. Dr. Ngoy, would you like to speak a little bit more about this?
Thank you very much, Tepiso, and thank you for colleagues who have asked the question. First of all, I would like just to bring a word of caution about the second wave, because I mean, sometimes words, they don't mean anything, but sometimes they do. If you compare the dynamic and trajectory of the pandemic, COVID-19 pandemic in Europe and in Africa, there's been quite a different kind of trajectory. So if we are looking at having the same kind of trajectory as Europe, we might maybe find ourselves that this is not exactly what is happening in Africa. So we might not really focus on wave per se. Though let us look at what is happening in Africa. And that's why Dr. Moeti was talking about the plateauing. What we are seeing now is, in generally as a region, that the decrease in number of cases has not continued to go down. Instead, we are having kind of a plateau. That's at a region level. But now when we zoom in the countries, we have some countries that clearly the number of cases are going up. That's what we're calling uptick. Now, this uptick, I was telling colleague this morning, I think as an African, you can look at that. The virus remains the same. I mean, so far we haven't heard about any mutation, at least. Then the biology more or less remain the same as human beings. We have the same kind of biology. The environment remain more or less the same. I mean, in terms of weather and so on, we can also compare with other Asian or even Latin American countries. So what can change? What can only change is human intervention. If we want to impact the dynamic of the pandemic in our region, is human interventions, including we can do human interventions on biology, as we're expecting from vaccine, human interventions on behavior, human behavior, and human interventions in the environment. So we can only count on what as a region we can do to really impact. So I would like really to emphasize, like, let us not really compare completely the wave, what they're calling wave elsewhere, and what is happening in Africa, because the dynamic has been so far a little bit different. So let us really focus on what is happening in Africa, even though we might not have that big wave, they call it wave. That's why we think in Africa, we should not maybe necessarily focus on the word wave, but what is happening in Africa, especially not at the regional level, but at country level, and even at subnational level. That's why Dr. Moeti was insisting the approach should now be in what is country, county, province, or even district is at most risk. And our interventions should be targeted and also targeting the risk factors. Thanks, Chapiso.
Thanks, Dr. Ngoy. So this next question is from Robert Butembo from the DRC, an independent journalist. Dr. Moeti, it's posed to you. It's about what the WHO is doing or planning to do to engage communities on fighting COVID-19, but specifically, he's asking about the RCCE and whether or not the WHO still needs it. So that question is from Robert Butembo in the DRC. Dr. Moeti?
Okay, thank you. And I agree very much with the focus of his question that engaging communities is extremely important. It's important at all stages of an outbreak of this nature, of this pandemic, but I think it's absolutely vital at the moment. So what we have been doing, we have a pillar in our response that deals with risk communication, it's called, this RCCE, and engaging communities, helping people to know about the disease, to understand, and to understand their own role and what it is that they need to be playing as individuals, in households, in families. So we're working on this with ministries of health, with partners like UNICEF, with some of the NGOs that are involved in community engagement. So the approaches are, of course, through supporting communication, ensuring that the right messaging with the correct information about, facts about the disease are disseminated through various media. We're also now emphasizing very much supporting engagement at the grassroots level through networks of people who are connected, associations, various organizations, so that the message is passed by people among themselves in the way that they will naturally be working together and communicating with each other. And what we have to make sure of, especially in the context of a whole lot of misinformation that we know is going on about the COVID-19, is to ensure that people get the right facts about what's happening in their locality, in their town, in their country, and understand what the situation is. And also, we've understood that there's a lot, some of the initial communication triggered fear, stigmatization of people or families that may or may not be infected, which were not productive in terms of the response. And most importantly, what people can do in order to minimize their own risk and in order to minimize transmitting themselves if they happen to be infected this virus to people. What I think needs rather more attention from ourselves and our partners is listening to people. So carrying out, if you like, listening surveys, conversations with people at the community level. And here again, I think that the networks, the organizations, such as the one that Regina is involved in, could play a really important role. So how enabled are people? What do they feel? Are they exhausted? We know that people are tired of the need to observe some of these precautions. We need to find ways, triggers, that will help people understand the importance of maintaining, sustaining this effort, especially now that the lockdowns and some of the measures are being eased. So what individuals do is becoming really vital to the success of the continuing reduction of transmission and the continuing reduction of the cases. And what I actually think is that when people really feel unable to do their part, it's important for us to know. So what help do people need? We can't assume that every family can afford a mask. We cannot assume that if there is a vulnerable person, an elderly family member, everybody can manage to isolate them. So I think we need to get more information about some of this. I think getting into some surveys, focus groups, conversations with people and their networks is vitally important.
Thank you, Dr. Moeti. And Mrs. Kamaga, you spoke earlier on about the need to strengthen at least what you said was patient self-management. Do you want to talk a little bit more about this, weigh in on this question that's been raised?
Come again? Sorry.
Would you like to talk to us a little bit more about this RCCE and from your experience, what more needs to be strengthened?
Again, just as I said, community engagement, community patient involvement through collaborative relationships is very, very important. And especially like the Dr. Matsa said, at the grassroots level, because for me, that's where it all starts. That's where the practical realities are. And I think COVID-19 has shown us, has given us lessons. And I think it's important that we all work together towards engaging and hearing, like you said, hearing the voices, the patient voices. When we talk about patients, especially in regard to COVID-19, it's pretty much everyone. We all patients in all this. So we need all to come together, support, give the support, and most of all, empower, because at the community level, there's a lot of misinformation and a lot of complacence where people still believe that COVID doesn't exist. It's for the West. So there's a need to, first of all, build the capacity of those community-owned resources who are going to pass on the messages, give them the correct information, give them the tools to be able to do what they do, incentivize them so that they're able to do the work that they need to do. I think for me, it will go a long way into helping us in this response.
Thank you, Mrs. Kamaga. We've got a question here from Rumbi Chakamba. And Rumbi, if you do want to ask your question live, as any of the other colleagues have mentioned, you are able to do so. Please indicate if you would like to do so. But I will ask the question though. So just pipe up if you are live and you want to talk to us. Rumbi Chakamba is asking, so she writes from Devex and wants to talk about the situation in Tanzania, saying that the government there has updated their electronic and postal communication regulations and added to that as a regulation which prohibits the publication of content with information regarding the outbreak of COVID-19 or contagious diseases in the country. Dr. Moeti, I think this is a question you may want to weigh in on. I think the question really is, what are the ramifications of this, especially if you are talking about the importance of community communications, and if you're talking about the lagging of essential healthcare services because of COVID-19.
Yeah. Okay, thank you. I think that clearly all means of disseminating information in the midst of a global pandemic, whether it be among people locally, whether it be more broadly, whether it be through the media, whether it be with partners, need to be taken advantage of. This is one of the advantages of the era that we're living in, that it's possible to pass information. So we want to encourage all our governments to enable the correct information, of course, as I said, and we are working to counteract incorrect information and misinformation. So we would very much encourage that information should flow. This is the advantage of the world we're living in today, and people have means of then disseminating information among themselves. It is important to counteract incorrect information, but I believe it is a lost opportunity to enable people to be empowered with information, not to use the means that are available today in order to disseminate this information. So I would say that we continue to be encouraging all our governments to enable and allow information to flow. I can also add, of course, that we have not had any reports of cases from Tanzania, nor reports of zero cases, which we ask according to the international health regulations, our member states who have signed on to this global treaty on the prevention of the international spread of disease to report to WHO. So we are, in a sense, in a position of not receiving any information from this country, which again, we have worked to continue to encourage, so that it is clear not only to WHO, but most importantly, is clear to the neighboring countries. You know, the international health regulations is a tool for encouraging the exchange of information publicly through WHO with neighboring countries to prevent the international spread of disease. So again, information is an extremely important tool of preventing both the national spread of disease, protecting people's health and lives, and preventing the international spread of disease. That's what I'd like to say in response to this.
Thank you, Dr. Moeti. I think, Rumbi, your question is also answered on what the impact is on WHO officials in this regard. Let's move on to this next question. It's from Marinella Corregia. She writes from a publication in Italy, and it's to you, Professor Adetifa. So, are there studies about the secret of Africa's COVID-19 experience in spite of the limited access to water and services, poor, overcrowded living conditions? So basically, she wants to know about the resilience that we've seen in Africa. She's saying that she's read that the young population is not the only explanation. May there be a low prevalence of chronic diseases like obesity, diabetes, or huge meat consumption as an answer? I think you get the gist of that, Professor Adetifa.
Yes, thank you for the question. I'm quite happy that Africa has had a different experience with COVID despite the predictions. And I would just like to add that, it would be nice for that question to also take into account that African governments and national public health institutes and partners, despite limited resources and some of the other problems that we know we have, actually responded to the pandemic very well. So we had a good response, one that was a lot better when people in some other countries of the world were debating about the use of masks or whether places should be shut down or not. We already did that with a handful of cases. And of course, that led to reduced spread, which is a documented fact. And that should be taken into account, where there are people living under overcrowded and poor conditions of inequity in health service and social standing all over the world. And we know from evidence elsewhere that those groups that are enduring most of the inequities also suffered significant burden of COVID in those very countries. Now, specific to our setting, I guess the simple answer is we do not know of all of the reasons why COVID has not had the same impact here. We do know from some emerging serology studies that significant numbers of the population across the continent have indeed encountered the virus and developed antibodies. So there is exposure. We think, yes, correctly, that the demographic structure or pattern of population in Africa may be one contributory factor. So we definitely have a younger population, and age is a risk factor for severe manifestation of COVID and death. And that's actually reflects in our case. If you look at the cases we've had, they are commonly severe in the older populations with more comorbidity. So we have a younger population. We probably have lower prevalence of the chronic diseases that you've mentioned. And some of the other things that have been considered is perhaps there is some form of pre-existing immunity because of a long-standing exposure to viruses that may be related to SARS-CoV-2. But these are all the subject of ongoing investigations. I know there are colleagues here in Kenya and my institution who are looking at immunity to COVID, and in Malawi, in South Africa, elsewhere. So we hope that we will find some answer, but I suspect, and this is my personal opinion, the reasons for the trajectory of COVID in Africa will be multifactorial, and all of those factors will need to be taken into account. Thank you.
Thank you, Professor Adetifa. Dr. Moeti, would you like to add to it?
No, I think he's given an adequate response. This is a recurrent question. We ourselves are wondering. We need to find out more about what are some of the factors involved. I think there are diverse factors, and I think he's mentioned them all.
All right, thank you very much, Dr. Moeti. So hopefully that answers your question, Marinella Correggia from Daily Il Manifesto in Italy. If there's anybody who would like to ask a live question, the opportunity is now, just before we get final comments from the panelists. So if you are able to unmute yourself and just pose your question. Okay, so if we're not getting anything, I'm just going to then go for final comments from the panelists. Mrs. Kamaga, let me come back to you. What can be improved in terms of community engagement? You did speak about the gaps. Are there any unforeseen gaps? What should countries be prioritizing? Mrs. Kamaga, you still with us?
Yeah, I'm here. I think in terms of priority, I'll start from the top. I think more than ever before, and given the lessons that we have learned, I think we need to prioritize healthcare service delivery, and especially at the primary healthcare level. That is very, very critical. And just also to say, and also to fast track universal health coverage, that is also critical. And, you know, for me, my biggest other issue is the reliance on external funding for our healthcare. That is, I can see sitting on a time bomb, and as evidenced by the COVID-19, where everyone else is really, you know, preoccupied with the problems happening in their own countries. So, yeah, but then going down to community, I cannot overemphasize the power of community. And for me, the priority should be in terms of involvement right from an early stage, even right from developing the strategies we're talking about that have been developed by the ministry, by, you know, the different partners, the presence, the participation of the community on resources at the table where those strategies are being designed, developed, I think is critical. And also the empowerment of these people, because many of these are like the village health teams, the community health workers, much as they're the first point of contact in the community, the doctors in the community, they don't have the capacity, they don't have knowledge. We recently organized a training to give them basic information on COVID-19. And it was amazing the low levels of awareness that they had about. So given the complacency, the misinformation in the community, and the fact that where they go to get information, that is the community health workers, they find that he or herself lacks the knowledge. So that is a big problem. So empowerment, involvement should go hand in hand with empowerment. And of course, the family, community, and the caretakers, all are critical. Religious and political leaders, cultural leaders at that level, all the stakeholders, the commitment of the stakeholders, and also being able to translate. We have all these documents sitting somewhere, and we are very good at doing those documents. But do they actually translate into action? Or is it just, you know, NATO just talking only and no action? So we need to translate theory into action to be able to respond to this pandemic that we are all facing. And yeah.
Okay. So just before I let you go, Mrs. Kamaga, we do have a question that came for you, and I think it's good to give the opportunity. So it's from Regina Camilla, and she says that Uganda plans to recruit 87,000 COVID-19 community workers. How do they need to be supported to work at their best to ensure that the community is aware of the disease to ensure infections remain low? Are you aware of these figures, and what will be the impact on current services if this will happen?
Yeah, very much aware. And like I said, the ministry developed a national community engagement strategy. And this strategy actually involves, bringing together the village health teams, community health workers, school representatives, and all those people at the community level to be able to respond to COVID-19. And it also involves, empowering them. But one thing is, like I said, it's about translating all these into action, but also the community health workers, the village health teams, they need to be facilitated. They walk long distances. They need to be motivated. They need to be supported to be able to do this work, because recruiting them without the tools, without the support, without incentives, will not yield the required results. And yet there are great potential, especially in this pandemic.
Thank you very much, Mrs. Kamaga. Professor Adetifa, we'll come to you now. You spoke about pools of susceptibility earlier on. Just going forward, what do you foresee, or what planning should be in place?
Well, thank you. I believe, as Dr. Moeti mentioned earlier, alongside the response to the pandemic, we do need to keep an eye on other problems, other services, essential services, especially immunization. The absence of immunization leaves children, large numbers of children, unprotected against the diseases for which the vaccines have been provided. And we have spoken about measles as an example. Our work in Kenya here suggests that if we conduct a measles supplementary immunization activity, as soon as restrictions are eased back, that would literally abrogate the risk of a measles outbreak. So my final remarks would be, it is essential that immunization services return to pre-COVID levels so that there's adequate protection for that cohorts. And it is also essential for the planned or suspended, delayed supplementary immunization activities to be executed as soon as possible, because the reasons for which they've been planned have not gone. In fact, the reasons for which they are required still works in the time that COVID intervened and they've been delayed. Over.
Thank you very much, Professor. Dr. Moeti, so we'll end with you. You spoke earlier on about the worrying figures of maternal deaths and how there's been a huge drop in antenatal care. And you also spoke about the huge number of children who are obviously also missing out on immunization. And just for me personally, I'm wondering, is there anything that we can do at communities to help stem these numbers? Mrs. Kamaga was speaking earlier on about capacity and knowledge. Is there something that the WHO can do, or that governments, health departments can do to capacitate and empower communities to be able to do this, so we don't have this high number of deaths, of maternal deaths, or even newborns?
Yes, thank you. I mean, I think just to go back to Ms. Regina's comment, I think knowledge, so enabling people to know that even as we are careful about the pandemic, it's vitally important to do your part to make sure that you seek these services for your child. And then we will be working with the government and the ministry and other partners to make sure that that service is available for you free of charge. I mean, in a way, it speaks to another point she made, which I think is very important, of ensuring that this dialogue and the contribution of communities happens at all levels, including at the national policy making level, so that when decisions are being made, the experiences, the perspectives of people from the community or those that represent them, those that are in touch with them, those that know at a level of detail what are their challenges, and sometimes what are their good ideas that can inform national policy and the implementation of programs so that they are more effective, that space be made. You know, and then now coming to what would be my final comments. We have worked a lot on moving towards universal health coverage, using primary health care as a vehicle and a strategy, which lays a strong emphasis on working with communities, dialogue with communities, mobilizing them for their role, including having community health workers as the interface and as prime movers for this. By the way, we have been recommending for some time now that community health workers need to be brought into the payrolls of the governments. There needs to be some predictability of the motivation and the rewards of these people, because otherwise it's very much low-income people, generally in many of our countries, being motivated very often by their low-income neighbors with whom they are working. So we are encouraging very much that progressively community health workers should be part of the system, including having allocation of funds to be available to motivate and to pay them in a predictable way as they engage in this work. It's very, very important. Finally, we're working towards what we call resilient health systems. So meaning when we are creating or building the health system for delivery of care, we also must make sure that it's capable of detecting and controlling outbreaks. So this experience has shown that another element of resilience is to be able to sustain providing healthcare services for other diseases that are important, because I think it was said very well that sometimes we see people dying, many more people dying of other diseases, other health problems, which then get, I won't say neglected, but which then get compromised by the attention and the risks in terms of responding to a pandemic like this one. And then you get distorted mortality, and you can roll back progress that has been made through investments over a number of years. I will finally just say that one of the concerns that we have, and here we have to both advocate for prioritization of health in terms of national budgets. We know that national budgets have been really severely affected by this pandemic, but the cost of not investing in health has been dramatically demonstrated by the economic impact of this pandemic. So what we are urging is that as we recover from this, please let's increase the allocations to health so that the resilience is built into our health systems. And next time there is a pandemic, the impact will not be so severe because our systems will be better able to respond and contain. And maybe the need for these drastic measures that were necessary now will be minimized. I'd just like to end there and thank very much our two colleagues from the scientific and also from the community level for what has been a very interesting conversation. We are determined to continue to support countries to make sure that we don't see these reversals that we've already started noting.
Thank you very much, Dr. Moeti. As you said, it's very important for us to protect the gains that we've already made, and you've made that appeal to communities, to authorities. And I think also our media colleagues, it's important that we put the information out there as well to empower people. Dr. Matshidiso Moeti is the WHO Regional Director for Africa. Thank you very much. She was joined by Dr. Ngoy Nsenga. And in Nairobi, in Kenya, we have Professor Ifedayo Adetifa, who's a clinical epidemiologist from Kemri Wellcome Trust Research Program and Associate Professor at London School of Hygiene and Tropical Medicine. Thank you as well to Mrs. Regina Kamaga, Executive Director, Community Health and Information Network or Chain, Chairperson of the Uganda Alliance of Patients Organization. Some very valuable insights from you as well. Thank you very much to all of you. This is how we come to the end of our briefing. Do take care. Enjoy the rest of your day.